Okay, so yeah, let's start with immunology today. And a lot of these topics in immunology, they're pure memorization, and whichever parts are pure memorization, I will let you know, and the other ones which are important for STEP, I will try to explain them in depth. Okay, so firstly, we have the structure of the immune system. Now, there's two different types of organs. In the immune system, you have the first degree or the primary organs, and then the secondary immune organs. The difference between these is that the primary organs, they're actually responsible for production and maturation of the, sorry, they're responsible for production of the lymphocytes and maturation, while the secondary, they're only responsible for storing all the lymphocytes and macrophages and neutrophils, all of those combined. So here the bone marrow produces the B cells and helps in B cell maturation, whereas the thymus, it only helps in T cell maturation. The production is still done by the bone marrow. So the bone marrow produces the T cells, and then the thymus helps in maturation. Secondary organs, any type of other lymphoid organ that you can think of, except for the bone marrow and thymus, would belong to the secondary lymphoid organs. So it includes spleen, lymph nodes, tonsils, adenoids, appendix, Peyer's patches, also the malt, which is in the small intestine, similar to Peyer's patches. Now, whenever they talk about a lymph node, there's a couple of things you need to remember, and it's majority of the times not about the structure that the exam will ask you, but rather the pathologies. So let's say follicles. Now, one thing about the follicles that they might ask you is about follicular cancer and sorry, a follicular adenoma and a follicular carcinoma. Now, there is one difference, and if you look here, this is actually a good image. So these are all the different follicles that you see in a lymph node. Now, this is an organ of this is a spleen, but you can still see them. These are the follicles. Now, one thing you need to remember is that if you have a membrane, so this membrane, if it's intact, then the cancer is contained within the follicle, and that's a follicular adenoma. And if the membrane is broken, if there is invasion of the cancer outside of this membrane of the follicle, that is what signifies that the cancer has broken through the basement membrane and is now actively invading the lymph node, and that is why we classify it as a carcinoma. So that's the USMLE thing that you need to remember about follicles. Now, think about this. The follicles usually have a lot of B cells. That's what the book tells us, that follicles have a lot of B cell localization. So if you have a cancer in the follicle of the lymph node, then what kind of cancer do you think will have?
Maybe like a B cell lymphoma?
Yeah, that is correct. So you'll have a B cell lymphoma. Now let's move on to the medulla. Now, medulla again, it's not a lot of cancers which actively invade into the medulla, but there is one thing that you need to know about the medulla, and that is that medulla contains the macrophages. So we said that the cortex or the follicles which are in the cortex, they contain lymphocytes, and then the medulla, somewhere here, that would contain the macrophages. Now, with the medulla and macrophages, there is one thing that you need to remember, and that is that a lot of clearing, a lot of elimination of the RBCs, that is done by these macrophages, which are in the medulla of the lymph nodes. Finally, we have the paracortex. Now, the paracortex, it's a small region. It's a transitional region between the follicle and the medulla, and that is one thing you need to remember. However, the questions that the USMLE asks you for the paracortex is majorly related to Digeot syndrome and additionally any kind of T cell disorders. Now, what happens is the paracortex, it contains a lot of T cells, and if you have a condition in which you have a deficiency of T cells, the paracortex would see atrophy or thinning. Now, Digeot syndrome here, do you guys remember the symptoms of Digeot syndrome? So I can tell you the mnemonic. It's catch, CATCH 22. So do you guys remember the symptoms? Okay, no worries. So the symptoms of Digeot syndrome, right, are cleft palate, abnormal faces, uh, thymic aplasia. That is why you have the hypoplasia of the paracortex or atrophy of the paracortex. Then you have cardiovascular deformities, so congenital cardiovascular deformities. They're also called cardiotruncal deformities because they also affect the truncus arteriosus. And finally, you have hypocalcemia. Now, the hypocalcemia that you see in Digeot syndrome is because of a atrophy or because of a failure of the parathyroid gland to actually be developed. Finally, the 22 at the end, that is responsible, that is in the mnemonic because 22 is the chromosome that the uh, condition happens on. Okay. Now, we talked about thinning of the paracortex. That the paracortex might thin or be atrophied if there is a decrease in T cells. So then, what do you think will happen if there is an increase in T cell production? What will happen to the paracortex? Yeah, so it will increase in size. Whenever you have an increase in T cells, the paracortex will increase in size. Now, why do we have an increase in T cells? There's multiple different reasons. You can have a fungal infection, you can have a viral infection. These are the most common, but any kind of extreme cellular response. So, any kind of extreme cellular response where your body is actively trying to fight off an infection and it's become chronic. In those cases, you can have increase in T cells, and because there is an increase in T cells, you'll see paracortical hyperplasia. That means the paracortex is increasing in size. Now, this part here is actually very important because let's assume that this part here is the paracortex, right? Yeah, let's assume that this part here is the paracortex. Now, if the paracortex it increases in size, it will push the cortex outwards, and that will ultimately lead to an increase in size of the entire lymph node. And then, what do you think is the term for an increase in size of the lymph node?
Lymphadenopathy?
Yes. So this is the reason why you have lymphadenopathy. So paracortex has T cells. Now, when those T cells multiply very rapidly, they can lead to paracortex hypoplasia, and that parathyroid hypoplasia will increase the size of the lymph node, and that is what will be called lymphadenopathy. So, any questions with the organization of the lymph node and the lymphoid organs?
That's good. Go ahead.
Okay. Yeah. Now, sadly, you do need to remember all of these. Not in depth. You don't really need to remember all of these lymph node drainages in depth, but it's good to have a general understanding of these lymph nodes. So this is something that you will sadly have to memorize. This entire table, you do need to memorize it. And when you memorize it, I'll tell you one thing, that you can forget about the associated pathologies here, and instead, if you can only remember like where certain uh, areas of the body are drained into, that will be more essential compared to remembering all of these conditions. And a lot of times, the lymph nodes that the organs drain into are closely associated with the vascular supply. So that is how you can remember them. Yeah. Now, this part here is actually important to remember, that the thoracic duct, sorry, it drains everything below the diaphragm, and it drains into the junction between the subclavian vein and the internal jugular. Now, why is this important? Because if you ever were to do a sorry, if you ever were to treat a pneumothorax, or if you were to do a lung injury and you accidentally poke at the junction between the subclavian and the internal jugular vein, somewhere here, you might see a problem where lymph starts draining into the lung and the thoracic cavity. Now, because lymph is draining into the thoracic cavity, that condition is called chylothorax. Now, couple of questions here. Uh, One, what do you think is the reason why we call this chylothorax? Why chylo?
I know that chyle is the word root for lymphatic fluid.
Yeah, that's okay. That's a part of it. But then, there is one very important thing which drains into the lymph nodes, which is chylomicrons.
Oh, is that has also something to do with triglycerides?
Yes. So
Okay.
chylomicrons, they transport triglycerides and free fatty acids from the intestine to the lymphatics, and then from the lymphatics they drain into the blood supply. So both of those, chyle, chyle or chyme, that is also translated into lymph, and it also has a lot of chylomicrons. And why I bring up the topic of chylomicrons, it's actually important because if you were to look at lymph, if you were to drain lymph in a test tube, what color would you expect the lymph to be?
Like a milky white?
Yes. And the reason why it's milky white is because of all the fat that it has. The reason why it has so much fat is because of all the chylomicrons which are deposited in the lymph.
Oh, okay.
Yeah. Now, there is one question that I have for you guys. Let's say that these chylomicrons, they enter the lymphatic system. So, which blood vessel, not blood vessel, but which vessel will these chylomicrons enter the lymphatic through? Like, what's the name of that vessel?
Dr. Taha, are you recording this lecture?
Yeah, I am.
Oh, okay. Thank you. I may have to listen to it 2 more times. I'm so sorry. What was your
That's not
question?
right.
Name of the vessel?
So, yeah, what's the name of the vessel into which the chylomicrons drain into so that they can reach the lymphatic system?
The thoracic duct?
No, they're actually called the lacteals.
Oh, okay.
So the chylomicrons, they're produced by the intestinal cells, and chylomicrons basically have packaged triglycerides, cholesterol, fatty acids, all of these things combined. They're packaged into chylomicrons, and chylomicrons at this point have become so big that they cannot directly enter the capillaries and blood vessels because the blood vessels around the intestine, they're pretty small. So they enter these large vessels called lacteals, which then eventually drain into the lymphatic system. From the lymphatic system, the chylomicrons, they travel to the thoracic duct, and then from the thoracic duct, they enter the venous system. That is why if you were to drain lymph near the thoracic duct, it will have a very milky white appearance, and it will be very high in fat content because it's primarily composed of chylomicrons and immune cells. Yeah. Now let's. So, any questions about this part about thoracic duct, chylothorax, chylomicrons?
I'm following.
No. So next we have the spleen. Now the spleen, it's a very interesting organ because it's basically a glorified lymph node. It's just a bigger lymph node. Okay, because it's a bigger lymph node, you have like more blood supply compared to the smaller lymph nodes. But the structure in itself is pretty much the same. There's a couple of differences, but the structure is essentially the same. Now, where is it located? It's located on the left upper quadrant. And yeah, you don't really need to remember this. But this part here, the splenic dysfunction, that is actually very important to remember. Now, why is it important to remember? Because the spleen, it does two very important things. One, it is responsible for production of antibodies. That's one. And the second one is that the spleen, it provides protection against encapsulated bacteria. Now, if the spleen is removed, or if you have a splenic dysfunction in which the spleen isn't acting properly, then you will have an increased risk of infection with encapsulated bacteria, and you'll have decreased antibody production. Now, which bacteria do you think will be more likely to cause infection in patients who have asplenia?
The sickle cell patients?
Oh no, which bacteria?
Oh,
Yeah. So the mnemonic here, right? You can remember it as Shin,
oh, shit.
Shin, which is wait, what was the S for?
Streptococcus
Yeah,
pneumoniae,
strep
Haemophilus,
pneumo, hemophilus.
and the Neisseria meningitidis.
Yes, Neisseria meningitidis. Yes. So Shin. So those. Now there is one more problem. Now because you're not producing antibodies, uh, obviously, if you're not producing antibodies, you also won't produce IgM. Now, one thing that you need to know about IgM, right, is the structure of IgM. So, IgM is one of those antibodies which is pentavalent. That means one IgM actually has five connecting points. So, it looks like this, and then all of these small branches they have the binding region. So, okay, right. Yeah. Let's say there is a bacteria which is attached to all of these. You guys can see the small image, right?
Yes.
Yeah. So let's say there is a
Yeah.
bacteria which is attached to all the like segments of an IgM. So what do you think? If a macrophage were to come around for phagocytosis, would it be easier for the macrophage to consume all of these bacteria together, or for all of them to be consumed individually?
All together.
Individually.
All together. Yeah. So the bacteria, sorry, the macrophage, will consume all of these bacteria together, and it basically increases the efficiency. So let me give you a quick analysis of what exactly happens here. So let's say you have multiple different bacteria. Okay. Now you releases a pentavalent. It's supposed to be a pentavalent. This has 6 ends. So it releases an IgM molecule, and this IgM molecule will bind to all of these bacteria, and it makes the job easier for the macrophage to phagocytose the antibody. Now, this entire process where the bacteria traps the antibody traps multiple bacteria and then allows the phagocyte to consume them is called opsonization. Opsonization is bringing all of the bacteria together. Now, let's say that you have a decrease in IgM production. So, a decrease in IgM production means that you won't be able to opsonize these bacteria properly. And now, if you cannot opsonize these bacteria properly, what do you think will happen to the immune system? Will it work at the same efficiency, or will the efficiency go down? Would it increase?
It will decrease.
Yeah, so the efficiency of these immune cells, it will decrease because now they have to individually go and pick up each bacteria rather than collecting them all together. So that's the problems that you can face with a splenic dysfunction. Now, one thing that they've mentioned here, and this is pretty important, is that patients with sickle cell disease can develop something called as autosplenectomy. That means the body itself just removes the spleen. Now, why does this happen? Is if we zoom in, sorry, you see these blood vessels here, they're pretty small. Now, if there are a lot of sickle cells and they occlude the entire blood vessel, the spleen it won't receive enough oxygen and will start to die off. So occlusion of the blood vessels in the spleen can lead to decreased oxygen and decreased ATP production by the spleen, and that will lead to autosplenectomy in patients with sickle cell disease. Now, one very important thing to remember is that this autosplenectomy it actually happens uh, till the age of 5. So after the age of 5, any kid with sickle cell disease does not have a spleen. That is an assumption that you need to make. Any kid with sickle cell disease is asplenic, means does not have a spleen, by the age of 5. So now let's say someone does not have a spleen. So what will you find in the blood? Couple of things. So you'll see Howell Jolly bodies. Now basically these are nuclear remnants. Now they just tell us that these are nuclear remnants. But which cells actually present Howell Jolly bodies? What do you guys think?
Um, red blood cells. I know it's on red blood cells.
Okay, so yeah, that is true. So in
Remnants of immature. Yeah, remnants of immature.
yes, so immature red blood cells, they usually have a nucleus, and then eventually this nucleus it's removed by the spleen, and now because you don't have a spleen, you'll still see those nuclear remnants in the cell. And that is similar with target cells. Target cells are cells which should have been destroyed, but they're not destroyed by the spleen, and that's why they're still in the circulation. And target cells, they look something like this. So it'll probably be an RBC, which has a zone. So it'll look something like this. Okay. Uh, Sorry. Next, we have thrombocytosis and lymphocytosis. Now, uh, thrombocytosis and lymphocytosis, it basically just means that you have more platelets and you have more lymphocytes in the blood and in the body in general. Now, why do these cells increase in case of asplenia? Is because the spleen, because it's so vascular. One second. Yeah. So because the spleen is so vascular, it holds a lot of blood cells. So it holds a lot of platelets, it holds a lot of lymphocytes, and it just holds a lot of blood in general. Now, if you don't have a spleen, all of these extra cells, all the extra platelets, all the extra lymphocytes, they all, sorry, all of these cells, they don't have a place to go anywhere, and that's why they end up in the blood. That is why you have an increase in platelets and also an increase in lymphocytes. Finally, it does tell us that you should vaccinate all the patients who come in with a splenic dysfunction because of the increased risk of encapsulated bacteria. So, any questions with this part up till now?
That's good.
Okay.
Clear. Thank you.
Yeah. Now we need to think about the different locations of the spleen. So, firstly, we have the periarteriolar lymphatic sheath. Now, what this entire thing means is that around the arterioles, there's a layer, and this is only for the arterioles, not for the veins. Around the arterioles, you have a sheath of lymphatic cells. Now, usually these are T cells. So, what do you think these T cells would do if they're around the spleen? And I mean, around the arterioles.
Hi, Dr. Taha.
Hello.
So the T cells in the periarterial, wouldn't they present look for the antigens, like which will be presenting by the antigen presenting cell to it so it can go ahead and activate the B cells?
Yeah. So that's actually a good answer. That they will grab the antigens. So one quick side note: the way this will work, right, is let's say there is a cell which comes in, and the cell has some virus inside. So the T cells will recognize the MHC class, recognize that oh, this cell is infected by a virus, and the T cells will consume that infected cell. Now, because the spleen is a lymphoid organ and it has both T and B cells, this will eventually lead to a cascade where T cells have phagocytosed a infected cell. They present it uh, on the antigen presenting cells, and from there you'll have the start of the immune response, the full body immune response. So yeah, that was a good answer. Now next we have the follicle. Now we already talked about the follicle, that the follicle contains B cells, and usually in the lymph nodes it was at the periphery. Now here it isn't really at the periphery, it's somewhere in the center, because the spleen doesn't really have a medullary region. Instead, it has a hilum where you have like the arteries and veins entering. So the follicle again contains the B cells, but it's in the center for the spleen. Now, marginal zone. Now, the marginal zone is an interesting region because it's the space around the follicles. Now, even in a standard lymph node, we said that there is a follicle which contains the B cells, and surrounding that follicle, we have a paracortex. This paracortex, it contains T cells in normal lymph nodes, but in the spleen, the marginal zone, that will again contain the B cells. Oh, sorry, yeah, it will contain the B cells, yeah, and also macrophages. And this is where the antigen presenting cells will capture the pathogens that I was telling you about. So once again, you have the arteries, and the arteries are surrounded by a T cell membrane, and in that T cell membrane, you have the follicles which contain B cells, and then between the T cell membrane surrounding the follicles is actually the marginal zone, which contains the B cells, which are specialized, so they're antigen presenting cells, and also the macrophages. So, any questions about the presentation and the structure of the spleen?
It's good, thank you.
Okay. Now, don't worry about these cells for now. When we study about all the cells, I'll tell you about how they all work out. But for now, just remember that these contain the antigen presenting cells. Next, we have the thymus. So, before we talk about the thymus, I have a question. Uh, is thymus a primary or a secondary lymphoid organ?
It's a primary, right?
Yes, it is a primary lymphoid organ. And then additionally, yeah, so it is a primary lymphoid organ. And then additionally, it also, sorry, yeah, it also is responsible for the maturation of the T cells. Okay. Now, the thymus, it's actually located here in the anterior and superior portion of the mediastinum. And there is one very important thing that you need to remember about the thymus is that it's usually present in children, and as aging happens, the thymus is gradually replaced by fat. And by the time people turn 30 or 40, the thymus has already vanished. So you might be able to see thymus in children, but you won't be able to see the thymus in adults because it's already been replaced by fat, and it's already consumed. Now this is one thing that you do need to remember, that the thymus contains these Hassel corpuscles, which basically contain epithelial reticular cells. It's just a fact that you need to remember. There's not a lot of logic behind it. And along with that, this is also a buzzword you should remember, that the thymus, it looks like a snail shaped finding on a chest x-ray. Now, again, an absent thymic shadow would basically mean that the thymus is not present, or it's very small in size. And there are certain immunodeficiencies which could do this. So you have SCID and Dijot syndrome. And once again, guys, what are the symptoms for Dijot syndrome? So we have CATCH, CATCH22. So
So C for cardiac defect, A for abnormal
yeah,
faces, T for thymic hypoplasia that you just
yeah,
mentioned, and then C for cleft palate, H for hypocalcemia, and 22 means because it affects the chromosome 22. I think it's 22q11 deletion.
yes, it's 22q11 deletion. Perfect. So those are the symptoms for yeah. So those are the symptoms for Dijot syndrome. Now, Dijot syndrome is one of the most high yield things you need to remember for immunology, and that's why I'm bringing it up so many times. Next, we have a thymoma. Now, a thymoma, it's simply a cancer of the. A thymoma is simply a cancer of the thymus, And there's a few associations here that you need to remember. All of these are important, except for good syndrome. But myasthenia gravis, important. And okay, let me ask you a question about myasthenia gravis. Are the symptoms in myasthenia gravis worsened or improved with prolonged usage?
Worsen.
Yeah,
Worsened,
Morrison.
yes. And then in which condition are the symptoms improved upon prolonged usage?
Lumperdine.
Lambert Eaton, yeah. Now, next we have superior vena cava syndrome. Now, superior vena cava syndrome, it's basically when your thymus has grown so large that it's actively compressing on the SVC. And because the thymus is compressing on the SVC, blood from the distribution of the superior vena cava cannot return to the heart. And that is what leads to the problem. So you'll see a very swollen and red face. Um, yeah, you might see an increase in ICP, all of those things. Now, the next one, this is a rare one for the USMLE, but they might ask you about this. Even SVC, I would say, is a pretty rare condition for step 1. It's more prevalent in step 2. So pure red cell aplasia, as it says. So it's pure, that means only the red cells are affected, and aplasia, that there is only a decrease in the number of RBCs. Everything else is normal, but there is only a decrease in the number of RBCs. And then finally, we have good syndrome. Uh, I'm not even sure what good syndrome here is. I've never heard of it. So, do you guys know what good syndrome is?
I think they met by good pasture.
Okay. I mean, if it's good pastures, then it makes sense. But I have no idea what good syndrome is, like on its own.
Yeah.
So, if there is a good syndrome, maybe there's also a bad syndrome.
It's true.
Okay. So, next we have the innate versus adaptive immunity. Oh, so actually, let me ask you guys. So, what do you guys think? Should we end it here for today, or do you want to continue with the adaptive and innate immunity?
I have no problem, Dr. Taha. Have you guys done
Wait,
questions? Sorry, I got late. Hello?
I'm okay with either way. I'm not very good at immunology, but I just want to mention this. I just Google good syndrome, and according to Dr. Google, it says good syndrome is a rare disorder that occurs in adults in whom hypoglycemia deficient in cell-mediated immunity and thymoma. So it's usually benign and may develop almost simultaneously. And it's increase in susceptibility of bacterial, viral, and fungal infection, as well as autoimmunity. Good syndrome is associated is the association of thymoma with immunodeficiency. It is rare cause of combined B and T cell immunodeficiency. Yeah,
Yeah,
that's
I
what
have
Google
never
says.
heard of this before.
It's okay. We'll learn together.
Yes.
You know a lot, Dr. Tahao. You don't know one thing, that's okay.
Yeah,
That's
there are
okay.
some syndromes, right, which just they're so rare that you hardly ever hear about them.
Yeah. So just B and T cell deficient immunodeficiency.
Yeah. Okay.
Okay.
So then let's.
Have you guys had a question?
Oh no, we didn't do any questions. I thought for questions, what we'll do is we'll complete all the lectures first, and after that we'll do the questions, because there is a lot of basic concepts, and then it's difficult to sort the questions through these concepts.
Okay.
So yeah, I was thinking let's complete all the lectures first, and then we can start with questions. So tomorrow maybe we'll try to
Okay.
complete the. Oh, wait, someone raised their hand. Oh, okay. It's the yeah. Yeah. So tomorrow we'll try to complete the innate versus adaptive immunity, also the MHC complexes, and okay, this one is memorization again. But yeah, we'll try to cover at least till the macrophage and lymphocyte interactions.
Okay.
Yeah. So